Morning, everyone. Gee, that really works in Greenwald. The mic is nice and booming. I'm Corby Kummer from The Atlantic, but importantly, we're all here to hear Dr. Thomas Frieden from the Centers for Disease Control, where he arrived in June of 2009. And before that, for 8 years, he was the health commissioner of New York City, where I first met him and wrote about him in The Atlantic. And he was one of the most progressive health commissioners the United States has ever seen. And we have his distinguished predecessor in progressive, forward-thinking role model department, Margaret Hamburg, right here in the audience. So we're glad to have all of you. Today we're going to be talking about the Centers for Disease Control. And everyone has kind of one idea of what the CDC does. If there's a disease outbreak, their loyal detectives sniff it out and track it, and they protect our health. But what does that really mean? And what does the CDC do? I don't think many people, including, frankly, me, before I was lucky enough to come to know a lot of people in the CDC, had an idea of the vast scope of it. So we're going to start off with infectious disease and some of the global tracking that the CDC has put into practice that uses technology. All of just the scope of it, I think, will come as a surprise. So what has the CDC been working on internationally with ID?
I think if you just step back for a minute, what does CDC do? We work 24/7 with boots on the ground to protect you from threats, whether they're infectious or chronic, whether from this country or abroad. And internationally, I think our biggest focus right now has been on H7N9, the new avian flu from China. In epidemiology and public health, when you think about influenza, that is the single biggest problem we could have. 1918, more than 50 million deaths around the world. And influenza each year causes tens of thousands of deaths in the US and around the world, both of people who are older and of young kids. So we have a serious problem. We're always tracking it. There's a global system that we have helped to establish in dozens of countries, tracking new strains of flu as they emerge. In late March of this year, China began identifying people with severe illness. They didn't know what it was. Because we had worked with them for a decade, they knew then how to diagnose it. They had systems set up to track it around the country. And within days, they had identified a new strain of influenza known now as H7N9. It's a bad news strain. This is a strain that kills about a third of the people it infects. It comes from birds, but it doesn't make the birds sick. So we can't cull the flocks and control it. It progresses very rapidly from infection to severe illness. We have very little immune response against it. We have essentially no antibodies against it. Mm-hmm. And the vaccines we can make for it don't work particularly well. They're likely to need 2 doses and maybe a chemical called an adjuvant to work. So we need to track this. Now what China did, first off, they were completely transparent. They posted the genetic sequence on the internet that allowed us to download it, make a diagnostic test that we've sent to every state in the country and more than 100 countries around the world. Also begin work on a vaccine with NIH, FDA, other parts of the federal government, the private industry, so that we could have a vaccine. All of that possible because China was completely open. They invited us in. We still have a team there now working with them to understand it better. They also closed all of their live bird markets, and that's probably what stopped spread of the virus from birds to people. What will happen in the fall? What will happen when they reopen the live bird markets? What will happen when migratory birds go elsewhere in that region? Only time will tell. But what we do know is we're better prepared than we would have been.
Can you tell us, the minute you say China was completely transparent, they couldn't have been more helpful. They closed all their live bird markets. Whence this openness and transparency? We all have memories of SARS and bird, and even the movie plot that had to do with bird, and somebody we all love to hate getting killed by bird flu in the end. Yes, Gwyneth Paltrow. So how is it that suddenly this changed? Was it international talks or a change in regime? Do you know?
Yeah, they looked at their experience with SARS and they said, that's not the way to do it. SARS cost the global economy $30 billion in just a few months. And there was an interesting statement early on in H7N9 where someone high up in the Chinese government said, we have learned that in the case of infectious disease epidemics, it's very important to be completely open.
Ah, so they made this public statement and they showed it. But were they in consultation with the CDC early on? And what about the recommendation to close all the live bird markets, which is something I think that a lot of people desperately wanted them to do the last time?
We have worked with them for more than a decade. Since SARS, they've said, we want to learn what to do. They've created something they call China CDC. It's called that in China, even though it means nothing in Chinese, huge 40-foot letters outside of their building. We're okay with them taking that brand in this case. But what they've done is to set up systems to monitor, to set up laboratories. We've helped them become a World Health Organization collaborating center on influenza, which sounds very bureaucratic, but what it means is they are required to post the sequence of every new flu strain they find on the internet right away. And that's what allowed us to figure out what it was and to begin making the diagnostic tests and to help the response. The closure of live bird markets is a tough decision because it's a big part of their economy. It literally costs
and their culture.
And their culture. It cost their poultry business billions of dollars in the time it was closed. Beijing kept theirs closed after SARS. But in the rural areas, it's much harder to keep control over that. So over time, that will be very hard to maintain.
And when are we to look for a new emergence?
Well, for H7N9, only time will tell.
We're just setting our worry clocks right now.
You know, all we can do is track it as well as we can, as intensively as we can, and prepare for a response as robustly as we can. And that's what we're doing.
And are there more international data registries that you think will enable quicker response to international disease outbreaks?
I think we've made progress. Flu is actually the area we've probably made the most progress in terms of global sharing. So when the MERS coronavirus hit in the Middle East, there wasn't a similar framework for sharing of specimens as there is, or genetic data as there is with influenza. But fortunately, between writing and academic articles and contacts and government relations, we now have a good sense of what's happening there. So I think we are growing in transparency globally, and it's important because we face a perfect storm of vulnerability. We are, on the one hand, better prepared than we've ever been for disease threats. On the other hand, we're also at bigger risk than we've ever been. We're at bigger risk.
How do those two things go together?
We're better prepared, we know better, we respond better, we're coordinating better, we have more political commitment because of SARS and things like what's called the international health regulations, which require countries to report conditions. But we're at bigger risk for basically 4 reasons. We've got emerging infections that continue. We get about 1 a year on average for the last 3 decades, some new, bad, deadly bug. Second, we have resistant organisms. Things like CRE, which is quick way of saying carbapenem-resistant Enterobacteriaceae.
Say it 5 more times. That's
CRE are basically deadly bugs that are resistant to just about every antibiotic we've gotten. They've come from overseas. They're now all over our intensive care units, all over the U.S.
By bugs, do you mean
Microbes,
virus, bacteria?
Bacteria, gram-negative bacteria specifically. So we've got emerging organisms, resistant organisms, globalization. Any virus is only a plane ride away.
Sure.
And a lot of our food supply and our medication supply comes from overseas, as Dr. Hamburg knows and addresses with the FDA. And finally, unfortunately, we've got great new tools that can protect us, but those same new tools can be used by bad people to make dangerous organisms and release them. So we have the ever-present threat of intentional release of deadly organisms. You know, we've had an anthrax attack already here in the US after 9/11, so it's not just theory that it may happen. So for all of those reasons, I think our risks are greater than ever, but our potential is greater as well.
Because?
Because we have more political commitment through SARS, through international collaboration, and we have amazing new tools, and I'll show you one of them. When I started at CDC as an epidemic intelligence service officer, no, it's not an index card. It is a chip, and I'm not selling anything for this company. It's just the only one that fits in my pocket. But this chip actually can sequence the genome of a microbe, of a bacteria or a virus in about 3 or 4 hours. It's got 11 million separate wells. With advanced computing, you then take tens of thousands of jigsaw puzzle pieces and you put them together. But we don't yet really know how to interpret it. We're just at the beginning of the genomic revolution in microbes. because we don't know which part of the genome will reliably encode for resistance for most of the organisms or for transmissibility, what's going to be more spreadable person to person, or which part of it we can say, if that's the same between these two people, they're epidemiologically linked. A lot of hard work needs to go on. New technology like this is great, but in and of itself, it's not going to solve our problems. We need to put it together, not just with informatics, but also with shoe leather epidemiology, with going out and asking questions. Where did you eat? Where were you hospitalized? Where did you potentially get exposed? And that's what we need to do next.
So while we're on shoe leather and the threat of international diseases, are there American boots on the ground in different countries, and do you help train teams to go door to door and use your survey techniques, or how does that work as far as international collaboration?
CDC has about 2,000 staff in 50 countries. And our core mission is, on the one hand, to save lives and protect Americans and people overseas, and on the other hand, to build the capacity of those countries that we're in to do what we're doing so that we don't have to do it. Some time back, the Assistant Secretary of State for Africa said to me that CDC is the 911 for the world. And that's great, but we actually want each country to have its own 911. So we've helped more than 30 countries establish epidemiology training programs, disease detective training programs. They've now graduated more than 3,000 disease detectives through 2-year training programs in their own country. 80% of them have stayed in their own country, and they're there leading the response to finding and stopping outbreaks. We've helped create the African Society of Laboratory Medicine. One of the things that PEPFAR has done, and PEPFAR has been an amazing success story in global health.
We don't need to be reminded what PEPFAR is? Okay. So
AIDS control around the world. The President's Emergency Plan for AIDS Relief, of which CDC provides about half of all the treatment.
And many of us consider the finest Bush legacy.
In recent years, we've been able to not only save lives by treating and preventing HIV, but also strengthening systems. So all over Africa, there are now laboratories that are reliable, that doctors and countries can rely on to accurately diagnose because of PEPFAR. All over Africa, women are more likely to get effectively treated in pregnancy. Children more likely to be immunized because of PEPFAR. In addition, as you may have heard last week, Secretary Kerry announced that as of now, 1 million babies have been born without HIV because of PEPFAR through effort around the world. An enormous.
Has that bought us goodwill in going to other countries?
You know, I think there are a few reasons why we should do global health. We should do global health to protect ourselves. Things like H7, where if other countries do it well, we'll be safer. We should do it because it increases stability. So if you look at cholera in Haiti, our effective response to cholera reduced the instability there. And we've actually made progress in Haiti so that there is now a greater and more robust health response, and because of that, a more stable society that less likely to have to go into and help. Third, economic productivity. People can buy our goods. We have a more vibrant global economy. Fourth is the soft power kind of effect. I will never forget the mother I met in Nigeria who was holding twins in her hands. And she said, "I'm HIV positive. My twins are HIV negative because of PEPFAR. Please go back and thank the American people for me." This is the kind of thing that we're doing because, as someone said, we are doing a great program because we're a great country. It's the right thing to do. For me, that's the ultimate reason to do global health, because all lives have the same sanctity. All lives have the same value, and yet every day we have so many people dying around the world, children, young adults, from diseases, conditions, injuries that are easily preventable with tools that we have today, but we're not applying. That's the sweet spot for CDC, going from we know what to do to we're doing it.
And you were recently in Asia, as in like yesterday, because everybody at Aspen has just come from another country and is going to another country tomorrow. So were you establishing different franchises? So is there going to be Singapore CDC and Japan CDC and you'll get lots of royalties? Or what were you doing?
Well, I was in Vietnam and Thailand for 2 different reasons with Secretary Sebelius. Vietnam is one of the areas where we're trying to go to the next level of helping them set up a system to find, stop, and prevent threats to health by laboratories, by disease detectives, by information systems, by rapid response teams and emergency operations centers, so that they can stop diseases there, they can be safer, and we can be safer. Thailand is a different story. We've worked with Thailand for 30 years. We've helped them train a whole generation of epidemiologists. The person who runs their healthcare system, and they have universal coverage in Thailand, was trained in the CDC training program, and he looks at data and uses data to make decisions on what they're going to cover in their healthcare system. Thailand as a middle-income country is a very different approach for us. What are we supposed to do? What's our role there? We're not giving them money to do big things, but we still have a key role in helping them figure out what to do, how to do it, so that they can respond effectively. They can learn lessons that we can learn from, and we can mutually move forward in global health.
But speaking of figuring out your role in other countries, your background is international health. I believe you lived in India and helped cure India of tuberculosis. But that you did TB work in India, so this is something that's extremely important to you. But how much is it a part of the CDC's charter, and who funds it?
Well, CDC, our role is to keep Americans safe. There's no way we can do that without working globally, because so many of our threats come from overseas. We also have a mandate through PEPFAR, which is our largest global health program. We also are the US lead for the polio eradication program. We've been working on this since 1988. We're closer than ever to the eradication of polio, but we've got real challenges in Nigeria and Pakistan. In 1988, there were about 350,000 kids who got polio that year. Last year, there were 225. In 2011, we had about a dozen outbreaks around the world. In 2012, we had none. 2013, we have our first in the Horn of Africa. We're dealing with it, but we need to get over the finish line. Disease eradication, eradication means it's gone forever, is the ultimate in sustainability and in equity, because it's forever and for everybody. And the other areas we work in global health include things like measles, where by expanding immunization, measles is a deadly killer around the world. We've prevented 4 million deaths in Africa in the last decade, and training programs and detection programs.
But do you have to find extensions of money? And then I want to move into ID in America. But is this actually part of something Congress funds you to do, or do you have to find adjunct funding?
All of the above. So Congress has specific programs that they fund for polio, for measles, for HIV, for disease detection. They also fund our general work, and we can't do tuberculosis control in this country where 70% of our cases come from overseas unless we also work overseas. So virtually every part of CDC has some global attribute or some global activity. To give you an example, you wouldn't think birth defects, which is a center at CDC, has a global component. But in fact, we worked for a long time with the Chinese 30 years ago to do a randomized controlled trial of folate in pregnancy to prevent neural tube defects, and that was what proved that it worked. And that's why we put folate in our wheat, and that's why we give pregnant women folate, and that's why we've reduced our level of neural tube defects dramatically and saved lots of money and lots of suffering.
So these are very useful domestically. You mentioned two diseases that are still big problems in the United States. I mean, at least two, AIDS and measles. What are you doing here for them, and what are other emerging ID threats we should be aware of in the United States?
Well, HIV, one of our biggest problems is complacency. People think it's not a big problem. In fact, it remains a serious problem, and we've actually seen increases in rates in young men who have sex with men in many cities in the US. And one of the things that we've learned globally is the idea of accountability and of getting people on treatment. In the US, less than 1 out of every 3 people living with HIV is effectively treated. Less than 1 out of 3. Because of that, we have a lot of spread of HIV.
That's kind of staggering. You just would not expect that. Why is that? Why is it so low still?
About 18% of people don't know they're infected, so you obviously can't be treated if you don't know you're infected. We only recently have come to understand that the earlier you treat someone, the better. So we're now saying basically treat everyone as soon as they're positive. But the single biggest reason is that our healthcare system is not as accountable as it could or should be. And we deal with this with every chronic disease, and HIV is now a chronic disease. The biggest reason why people are not effectively treated is because in some way or other, they're no longer in care. The healthcare system didn't reach after them. They fell out of of care. No one was accountable for ensuring that they were offered effective treatment and given every opportunity to take it.
They're two different things, though. It's whether there are effective treatment protocols in place that are up to the minute and not just kind of rich people who can get the better care. And also, I'm hoping that ACA, the Affordable Care Act, is going to solve a lot of this. Is it?
It has tremendous potential to do a few things. One, it's going to increase coverage. So tens of millions of people are going to have health care coverage who didn't have it before and wouldn't have it otherwise. Second, there are things like the accountable care organizations that will make it in the interests of healthcare providers to make sure people do come back for care. And third, it's making things like HIV testing available free of charge to a larger number of people. I'll tell you probably the single pivotal moment in my life on this issue. My first big job was working for Peggy Hamburg, trying to control tuberculosis in New York City. It was the early 1990s. Tuberculosis was on the headlines, major news story. People were dying in hospitals. Prison guards were dying. It was spreading all over the city. There were outbreaks in hospitals. Hospitals were in panic over it. And I was working as hard as anyone can work to try to stop it. A man named Carol Stieblo came to New York City. I didn't know who he was. He actually is the man who created the global strategy for tuberculosis control. But I didn't know that. He looked through our information summary, which had all this data about where TB was and where in the city and what kind of TB and what was happening. And he pointed out to me things that I had missed in that information summary, which was a little galling because I had written it. And then he asked me the single question that changed my life. He said, Dr. Frieden, I see from this summary that last year you diagnosed 3,811 patients in New York City with tuberculosis. I said, yep. He says, and this book tells me all about those. Yes. There's one thing it doesn't tell me. I said, what's that? It doesn't tell me how many of them you cured. And he was right. It didn't. And I was terribly ashamed. And the next day, I started a system to review every single patient we had diagnosed with every single part of the city and to ensure that we were holding ourselves accountable for how they were doing. And that's what we need to do in the healthcare system, not just for HIV, but for high blood pressure, for high cholesterol, for cancer screening and follow-up. Until we have that kind of rigorous accountability, we will not get value for our money.
Is that what led to DOT, one of my favorite acronyms, Directly Observed Treatment?
That's related to it. You can't actually get to a very high cure rate in tuberculosis unless you ensure that patients are connected with the system. You build a human bond to get them through what is still a stigmatized and terrible illness which you feel better after taking a month or two of medicine for.
Same thing with HIV and other chronic illnesses.
That's right.
People don't comply.
They don't comply. You know, taking a medicine reminds us that we're mortal, and none of us like to be reminded that we're mortal. So we need some way
Oh, here
to
we're
ensure.
all very adult about that.
Okay.
It's
But
one exception.
we need some way to make sure that people get the care that really makes a difference.
What about other non-communicable illnesses? Let's start talking about some of the big threats to mortality that can be controlled. For example, just the small matter of tobacco.
Well, you know, in this audience, there may be a temptation to think that nobody smokes anymore.
And if we ask how many people here smoke, there would be no hands because you would all be too ashamed to admit it because shame is an important factor in reducing tobacco use. No, it really is. It's an actual strategy.
We call it by a more polite name.
And what's that?
Social norm.
Oh, social norms. So I think that's a very useful euphemism we've all learned today. Let's change the social norms here.
Tobacco remains the leading preventable cause of death in this country. It kills 440,000 people a year. About 1 in 5 adults still smokes. And it accounts for about $200 billion a year in costs. Half economic costs, half healthcare system costs. And most people who smoke started as kids, and most of them want to quit and try to quit every year. So tobacco remains our single leading preventable cause of death. We've made some progress in recent years. In 2009, Congress passed and the President signed a bill that gives the Food and Drug Administration authority to regulate tobacco. Within the Affordable Care Act, We have a prevention fund, and for the first time ever, we're running national anti-tobacco campaigns. Last year's campaign was successful beyond our highest expectations. We had more than 100,000 people quit smoking because of that campaign. It overwhelmed quit lines all over the country. And what we have learned about tobacco education is that what works is showing people what we as doctors see day in and day out when we take care of patients. We pull back the curtain and we show what it's like to take care of someone who has emphysema or cancer or a heart attack or a stroke or an amputation, or who dies before they can see their child graduate. That's the reality of smoking. And as healthcare professionals, that's what we see, and that's what our campaign showed. Also,
when you say campaign, do you mean some of those very scary campaigns that you did in New York City, that we adopted in Massachusetts, and that Australia is? Have any of you seen the Australian anti-tobacco campaigns? The scariest, most frightening, hideous pictures.
Actually, Massachusetts did it before New York City. They had a great ad that we just adopted and ran. Australia has done a terrific job on these ads. Yes, we did it in New York City, and yes, we're doing it nationally now because it's proven, because we know it gives us a great return on investment. We know that by getting 100,000 people to quit smoking, a smoker costs about $2,000 more to care for per year than a non-smoker, and that's cut in half when they quit smoking. So an ex-smoker still costs more than a non-smoker, but only half as much more as a smoker. So you save money and you save lives.
But the money you said was for education, but I assume it's also to man quit lines and for quitting programs.
Well, the question of what you use a tobacco tax for is a political question. I will say that in 2009, I know Peter Orszag is at this conference, and he was really important in pushing for the 62-cent tobacco tax that was passed in 2009 that funded the expansion of children's health program, CHIP, around the country. That 62-cent tax probably helped more than 1 million Americans quit smoking. More than 1 million. Now, about a third of them would have died from tobacco use if they hadn't quit. It's not every day that a government policy can prevent more than 250,000 deaths. I mean, this is a tremendously successful policy. Of course, globally, tobacco remains a huge challenge as well. In this century, it will kill 1 billion people. Today, it kills more people than HIV, TB, and malaria combined, and the numbers are increasing. So in the US and globally, we need to do more on tobacco. It is the leading preventable cause of death.
And the next question is something I think you're going to say next question to. But this obviously brings up to all of us in this audience the idea of taxing food, taxing sodas that we think also lead to obesity. And we're about to get into obesity. But the strategy of using a tax to put into health programs, public health programs, to save the healthcare system enormous amounts of money down the line, and hope that it will have a salubrious international influence. For example, a lot of the reason one could posit that tobacco is such a huge international problem is because if we're very effective in reducing tobacco use here, marketers will find markets in other emerging, westernizing the global south, and that will continue to be a problem there. The same thing might happen if there is, something like a food tax. Are we going nowhere near that?
If you look at what are the lessons from tobacco control for other public health problems, because we've made a lot of progress with tobacco, even though we have so much further to go. Mm-hmm. There are 3 main strategies that together have changed that social norm. In tobacco,
social norm, everyone.
We've changed it from "would you like a cigarette" to "do you mind if I smoke?" That's a huge change in society. But
that's more than that. We've pushed people outdoors.
3 things. We've changed the price, we've changed the access, and we've changed the image. So price is from things like taxation. Access is from things like smoke-free places, and whether kids can get cigarettes in vending machines or in stores. And we've changed the image by hard-hitting ads and by reducing, not eliminating by a long shot, by reducing the amount of advertising, marketing, promotion the tobacco industry does. Those same 3 components are likely to be relevant for various other things. But in obesity, if we're completely honest, we'll say we don't know what's causing it. I can give you 4 or 5 mutually exclusive explanations of why we're in the midst of an obesity epidemic, and they're all really convincing, and they can't all be right. We also, because of that...
They're really mutually in conflict? They couldn't all be right together and be contributors?
That's another possibility, but we don't know. We really don't know. And because of that, we don't know exactly what will work to reverse it. What we do know is that we've got to try things. We do know it's a really serious problem. It's causing more than a quarter of our healthcare inflation. It's causing huge disability. Our diabetes rate has doubled or tripled. Our children have increased in weight faster than anyone would have thought possible. The health consequences of obesity affect virtually every part of the body. So it's a serious problem. So what do? We try things. I mean, that's what we did in tobacco control. When California started going smoke-free in communities, we didn't know if it would work. Now we know that if you go smoke-free, it doesn't hurt business, it saves lives, it probably even reduces heart attacks in people who don't smoke. So we need communities to try things and rigorously evaluate them. That's what we're about. We're not about doing what we think works. We're about being rigorous and doing what we are certain will work. And if we're not certain what will work, then trying something and rigorously evaluating it.
That makes enormous sense. To try it, get the data on it, that's what a lot of healthcare is doing across the country, especially in the wake of the Affordable Care Act and in anticipation of it. But what are the programs you'd like to see enacted for obesity control so that before pushing for a national charge, you would have data on it? You were active on taxes in New York City. That is a fight that continues to be fought. Do you want to see that being fought locally on local levels to get an idea of whether that's one lever? What are some of the other levers you'd like to push?
Well, there are certain things that we've seen that are really encouraging. Some of them I wouldn't have thought would be that high impact. One is government buys a lot of food. Changing the food government buys and provides to people can make a huge difference. So, for example, prisoners, homeless centers, senior centers, daycare centers, schools, child cares. There are military procurement, billions of meals being bought by the government. And if we can just move that over to a bit healthier, it can make a huge difference. Also, encouraging physical activity, figuring out how you can get people active. Physical activity is the closest thing we've got to a wonder drug. If you're physically active, even if you don't lose 1 ounce of weight, you're less likely to have diabetes, high blood pressure, high cholesterol, depression. You're more likely to be free of cancer. You're more likely to be more active. You're less likely to get Alzheimer's, most likely. So the benefits of physical activity are enormous, and yet the ability to really scale that up in child cares, in schools, in communities, in senior centers, there are great things being done, but we need to see what works and what works in a way that's scalable. We think a lot about the concept of scalability. It's not enough to do a great program that helps a few people. Mm-hmm. You have to reach scale if you're really going to make a difference in society. And that's where we try to put our efforts. What we want to see is different communities trying things and figuring out what works. We're seeing some progress. There are about a half a dozen, maybe 10 communities around the country that have shown 5, 10, 20% reductions in childhood obesity in the past few years. It's not a solved problem. We went from here to here and now down to here in a few places. So we're still way worse than we were a generation ago, but it's going in the right direction.
And my guess is that those communities used a variety of approaches and there were no magic bullets, because in all of this, no matter what your favorite remedy for obesity is, there's no data that shows it. So were they all multifactorial, like nutritionists, help eat fewer calories, help increase physical activity?
They did many different things, and we're trying to kind of sift through that and see what were the common denominators in different places. School policies, child care policies seem to be quite important and not that hard to do. Making water available freely in child cares and in schools and cafeteria lines displaces high-calorie drinks. Doing things that are simple, like putting the fruit first in the lunch line, can make a big difference. So they're doing a better job with physical education class. One of the real travesties of our physical education experience in this country, education is so important, there is sometimes a sensed conflict between whether you've got phys ed class or you've got reading and math. But the evidence is pretty strong that the more physically active kids are, the better they learn. And if they're not bouncing up and down in the gym, they're going to be bouncing off the walls in the classroom.
So two simple approaches that you've been very behind. One of them is the Million Hearts Initiative, which has the Know Your three C's, 4 A's. What was it?
ABCs.
Know Your ABCs. Thank you. That and national sodium reduction, which is another incremental approach, and that's not to do with obesity necessarily. That's another public health issue altogether. Tell us about it.
Million Hearts is a campaign that we launched with the private sector and the Center for Medicare and Medicaid Services that we think can prevent 1 million heart attacks and strokes over a 5-year period. We're going to do that by two broad ways: helping people be healthier and improving the care they get when they need care. In that first bucket is tobacco control, like the ads that we're running, and the president has proposed a 94-cent tax to fund early childhood education in the 14 budget. That would reduce the number of smokers.
94
cent per pack.
That good. I'm glad. I thought it was 93. Okay, I'm glad you mentioned that.
That would help more than 2 million Americans quit smoking. It would save hundreds of thousands of lives. So tobacco control is one. Eliminating artificial trans fat, which you and I spoke about the first time we met. This is a substance that's added to our food to increase shelf life. The food industry has gotten a lot of it out, about half of it out. And companies like Walmart have committed to getting the rest out. But it's still out there, and it's still hardening our arteries without our knowledge and consent. So getting trans fat out of the system and reducing sodium levels. We consume way more sodium than we need or is good for us, and it's not what you add at the table. What you add at the table and in the kitchen is only about 10% of the sodium you consume. Nearly 80% of the sodium we consume is in packaged and restaurant foods. Now, we want to put power into people's hands. If you want to add salt, go right ahead. But you can't take it out once it's there. So we want to work with the food industry and the FDA to reduce sodium in foods, and that will reduce our blood pressure, and that will reduce our heart attacks and strokes. In the care side, it's the ABCs: aspirin, blood pressure, cholesterol, and smoking cessation. If we do those 4 things well...
That's ABCS.
ABCs. I
or
said ABCs.
ABCC for cessation.
ABCS, smoking cessation. If we do those 4 things well, we will prevent over 100,000 deaths a year. And right now we don't. Take blood pressure, which is probably the single most important one. Only 47% of Americans with high blood pressure have it under control. That's despite the fact that the medicine to control it can cost pennies a day, and that health systems that have focused on it have gotten to 90% control. In other countries, they've gotten to 70 or 80% control. And it's not just a question of access. It's also a question of quality. And we've learned a lot. I think many people here are very concerned with healthcare and how we can do a good job in improving our healthcare system. We've learned in this program that there are 3 essential ingredients to improving the quality of healthcare once you have access. One of them is focus. So the systems that have made a difference on blood pressure control have fed back to every doctor every month what their personal control rate is among their patients. The second is information systems. We're in a revolution in health IT. We're just beginning to figure out how to use it well. But that system allows practices to dramatically improve their performance. And the third is teams. Doctors, they send us to medical school. They take the neurons out of our brain that allow us to follow protocols. When you have nurse practitioners, nurses, pharmacists, allied health workers working together with doctors, following not cookie cutter, but a standardized protocol that can be adjusted with dosages and medications, you get much better control rates than if you try to wing it. And so that's possible through involving other members of the healthcare team. And that, frankly, is the only way we're going to improve quality, reduce costs, and increase employment in the health sector, is by using a broader array of health workers to deliver value to patients.
And these kinds of teams, we hope, are going to be part of what accountable care organizations do, and that's part of the ACA, the Affordable Care Act. But in this, we're about to go to questions, so think of your questions. Please, no, we're about to. Glad that there's somebody ready with one. You've outlined this enormous wide range of challenges, and none of them have, well, some of them have obvious constituencies politically. But how do you line up the political will to get the funding for the budgets that this vast, kind of unfathomable array of tasks requires?
The more specific we are, the more support we have. So if we focus on immunization, we have a great coalition that has moved immunization forward in this country. We're not where we need to be, but we're doing a good job. We've eliminated racial and ethnic disparities in immunization coverage in this country. That's a tremendous accomplishment.
Huge.
Yes, and that's because of the Vaccines for Children program, which we administer, that was passed in the 90s, that says that, it makes sense to vaccinate all kids so that we're all protected. And that's been a great accomplishment. But we need to identify that in other areas because, all too often, public health is about the general good, and nobody ever held a rally on the steps of Congress or City Hall to advocate for the general good. So when people are advocating for public health, they're advocating for things that are protecting all of us, that are really living the reality that we need to be there to protect you. With sequestration, we had a $300 million cut at CDC. 2 out of every $3 that we spend go out to the front lines to help find and stop outbreaks. There are going to be thousands fewer disease control specialists in all 50 states because of sequestration. Our threats to health didn't come down by 5%. So our preparedness and our ability to respond to them did.
That's pretty scary. So questions, the first one is that one that was all pre-prepared. There's a mic right there. Then the gentleman.
Hi, what's the CDC doing to educate the excessive use of antibiotics, the prescription of them when people are not sick and they take them just preventively to help against, not being able to react when you actually have the disease?
This is a big problem, and we've just released new data showing just how common antibiotic use is, and it's causing an increase in drug resistance. It's causing an increase in an infection called C. difficile, which is very severe and can kill people.
And I hate to say what one of the new remedies for C. difficile is, and so I won't look it up on the Atlantic's website.
Thank you. It's too close to breakfast.
Yeah, that's right.
We're working with doctors, we're working with professional organizations, we're working with insurers, but we also have to work with the public because we need to get the message across that more is not better, better is better. And that taking antibiotics is not a benign thing. It has all sorts of implications. We don't really understand all those implications for your gut flora, for how you absorb nutrients, and how that might change things. So backing off on the inappropriate use of antibiotics is very important. But it's going to be a big challenge because it's the path of least resistance. And one of the secrets of public health is trying to make the healthiest path the path of least resistance. In the case of antibiotic overuse...
The secret of politics.
Well, in the case, I don't know how to respond to that. In the case of antibiotic use, frankly, things that have made it harder for doctors to overuse antibiotics have reduced utilization. So putting in programs to get appropriate use. We don't want to deny people who need treatment, but we also don't want to have excess treatment because all of us suffer for that.
Gentlemen.
Thank you. We're just about out of time, so I'm going to make this quick. I'm a physician scientist, and many of us believe that the epidemic of obesity is in large part due to carbohydrates and sugars and the enormous amount we eat. But there's no dietary science to prove that. And furthermore, I don't know of any good research that's going on. Peter Attia has raised $100 million of private money for something called the Nutrition Science Initiative. Do you see anything coming from Congress or the government to give us some nutrition science? And the other thing that I think is very important for everyone to understand is I think there's almost no scientific basis for the dietary recommendations.
You ask one question, may we have him answer that question?
Well, this is part of the same question.
Okay.
There's no scientific basis for the recommendations, or very little anyway, of the recommendations of the American Diabetes Association and of the U.S. Department of Agriculture. Those things were made up out of people's heads in the 1960s at the NIH with very little scientific basis.
Well, I would say that the dietary recommendations that we participate in are based on the best available science. But the science is not as good as we'd like. There is some research going on. There's actually pretty good coordination across NIH, CDC, and other parts of the federal government to identify, but there's a need to find out more. There's a need to try things, study them, learn more. As I said earlier, there's a lot we don't know about obesity, but there is a lot we do know. Eating less makes a lot of sense. Drinking more water makes a lot of sense. And beyond that, you get pretty controversial. But more fruits and vegetables is going to be important in any situation. But there are real challenges, and I think one of the things that we try to do at CDC is to be an honest broker. Never to overpromise, never to overstate. So we try to keep clear, this is how far science takes us, and here may be a reasonable place to go given the best available data.
Lady, and then she's going to pass it to the gentleman in green.
Hi, thanks. Dr. Frieden, I'm Meryl Chertoff from the Justice and Society Program, and we've started a new Excellence in State Public Health Law Fellowship working with the states. My question for you today is, obviously a lot of the work that you're talking about is CDC driven, but a lot of what goes on at the public health law level is happening in the localities and in the states. How can we help state legislatures to overcome short-term thinking and think in terms of long-term public health goals, which will bend the curve in the long run?
And then extend that to the feds, please.
State and local levels are the most likely places where we will see new things tried, experimentation, progress. Washington State just reduced its prescription opiate overdose deaths by more than 20% in 3 years. So I think identifying success stories, success breeds success, and helping state, I wouldn't neglect local, city, and other legislatures and legislative bodies, find things that work, copy them from other places, adapt them from other places, evaluate them. I think there's a tremendous potential for progress at the state and local level. At the national level, much harder.
But look at Massachusetts, I say loyally.
I'm Kurt Malkoff. I'm a PhD clinical psychologist and know enough medicine to be a little bit dangerous. With that said, you made a point that for the last 30 years, something comes up each year and we're sort of chasing this gram-negative next microbe. Some might say that antibiotics is so 1945. Do you see a day where we're not talking antibiotics and treating these diseases differently?
Or there's so much antibiotic resistance that we won't have effective
Yeah,
treatment.
I mean, it's a 75-year-old clinical response. It's tired.
Well, I think it's tired, but it's going to be necessary for a long time to come. We need to try to find new therapies, immunological therapies and others, but we're going to be using antibiotics for a long time.
That side of the room, we should go to the gentleman in blue and then lady in black.
So I keep seeing all the things from like Jenny McCarthy about the evils of vaccines, and that just kind of makes me sad that people like that have a national platform. What are you doing to counteract the pathetic excuse of science that they claim that vaccines don't work, that sadly people believe?
So sunlight is a great disinfectant. Instead of saying, really forcefully, no, they work, we say, we understand your concerns. Here's all the information. Here's all the data. About a week or two ago, we released information on the human papillomavirus vaccine, HPV. Only 32% of American girls are fully vaccinated. 32%. Rwanda is at 80%. If we were at 80%, among the girls aged 0 to 13 alive today, there would be 50,000 fewer cases of cervical cancer in their lifetimes. For every year we don't get to 80%, 4,400 women will develop cervical cancer. So we try to correct misinformation with better information, good information, and from many different sources. It's important that people hear that from the parts of the community that they trust.
Lady in black, next.
Hi, Mercedes Garrity from Puerto Rico, which is a U.S. territory, by the way. I'm concerned about the status of staph infections in our hospitals. What is the CDC doing about it? I know there are states who are not required by law to inform, and I think that's one of the cases for us being a territory of the U.S. And I want to know what we're doing internally to try to correct that and prevent people from dying in our own hospitals.
We have a very active program of preventing hospital-associated infections. We've reduced some of them by about 50% in the last decade, but we've made very little progress against others. Now, virtually every hospital in America reports into CDC. Wherever the state allows us to, we share that data with the state. Wherever we have dollars, we provide state governments with resources that they use to improve practice within the states. States are essential here. We're working closely with CMS and others to disseminate best practices, hand washing, simple tools. We just released a clinical study that showed almost a 50% reduction in infections from very simple prepping and antibiotic ointments that were used on hospitalized patients. So we think that drastically reducing healthcare-associated infection is a winnable battle. We've had great partners in groups like Consumers Union, Consumer Reports, and consumer pressure and patient pressure makes a huge difference, and I think we can make even more progress.
So you mentioned the issue of increasing rates of HIV amongst young men who have sex with men. What is the CDC's prevention strategy?
Right now, we're really doubling down on the question of treatment as prevention. If we can get people tested, get them on treatment, we know that if you're treated for HIV, your risk of spreading it to someone else goes down by 96%. If we can get, instead of 28%, 88% or 68% of Americans with HIV having their viral load suppressed, we will drastically reduce spread, we believe.
Gentleman right there.
I'm Steve Levine with Levenger. As director of the CDC, is there a nightmare scenario that keeps you up at night?
Well, the fact is...
Is there one? Is there just one that keeps you up at night?
The fact is I have great staff. And so I can rely on the incredible scientists of CDC. We have 11,000 staff. They're the world's experts in every disease, including a bunch that you've never heard of because they're the world experts in it and they're controlling it. But if there's one thing that worries us most about a new and emerging problem, it is influenza. Because influenza has the capacity to kill tens of millions of people. That's why we are so committed to tracking what's happening around the world, to responding rapidly, and to preparing to see what would we do to get a vaccine out, and until the vaccine came, to get medications out, and for those for whom that doesn't work, to make sure they can be adequately cared for in hospital.
Gentleman there.
China is facing hundreds of millions of deaths.
China's facing hundreds of millions of deaths, and now he has the mic.
From tobacco-related disease, cancer and other maladies. Do the Chinese recognize the scope of their problem, and are they prepared to do something about it?
If you look at what's happening with global tobacco control in the past few years, there is the beginning of a sea change. Russia has now passed very comprehensive laws about tobacco control, which was inconceivable a few years ago. China understands what the problem is. They're not yet taking action on it. But tobacco use in China will kill 100 million people among the people alive today. So it is their biggest problem, and they need to make a lot more progress.
But, you know, they can just whistle away their cares.
Jurisdiction, but I know people who have had physical exams for various reasons, general exam or for dermatology, skin cancer. Is there a standard that you have so a physician who does an exam must fill out and know that he follows all the normal routine steps? I know people who have died of cancer of the ear because they weren't examined, etc. Is there any control you have, or any plans, or any format?
You know, it's a hot topic, because if you look at evidence-based medicine, it's not so clear what's important and effective in a physical exam. However, if you look at a great clinician, they are artists in what they do in physical examination, but it is largely a dying art. Standards of practice are not set by CDC, they're set by professional societies, they're set by what insurers reimburse for, and physical examination, unfortunately, is a dying art.
So with that and the importance of clinical care, I not only want to thank all of you, but we have the two defenders of the nation's health in this room. There's another entire empire we didn't even begin to discuss, but many of the concerns are shared, of Dr. Hamburg here. So I'm very honored, and Aspen is honored to have them both with us. Thank you very much.
Thank you.